Today's case is Mrs. A.
Can I ask you a question?
Yes, sir.
Why did you choose this rare disease case? Huh? कोई स्पेशल कारण?
फर्दर इवैल्यूएशन में जब अभी कर रहे हैं अभी पेशेंट को तो थोड़ा
कुछ और निकल रहा है। चलो बहुत अच्छी बात है। कुछ सरप्राइजेस हमारे लिए भी छोड़ दिया करो। चलो हाँ जी।
Mrs. A, 33 years old female, resident of Noida, homemaker by occupation, presented with chief complaint of swelling of body for the last 2 months and joint pain for the last 1 month. History given by the husband and seems reliable. History of present illness. Patient was apparently well 2 months back when patient noted facial puffiness on waking in the morning, which was swelling was more during the morning and used to improve after the evening. After few days, after 7 days around, after few days around 1 week, she also noticed swelling in both feet, which was insidious in onset, gradually progressive, increased up to the ankle and later on evolved up to shin over the next 20 days. Patient also noticed proteinuria in urine at same time, and there is no diurnal variation. There is no history of orthopnea, abdominal distension or dyspnea on exertion. At that time her urine output was also normal. There is no history of chest pain, no history of pain and color change in the swollen limb. There is patient consulted local practitioner and she was prescribed some medication which she was not able to recall, had partial recovery. She also complains of multiple joint pain for the last 1 month, which involves all the joints of both upper and lower limbs and not associated with swelling and redness of joints, and there is no history of any morning stiffness, and there is no joint pain is non-migratory and it was relieved by taking medications. She consulted at a local hospital in Noida on 8th March, and on evaluation she was found to have high blood pressure and her serum creatinine was 1.1 at the day of hospitalization, and she had anemia, low HB and platelet as told by the attendant. She was also told that she was leaking protein and blood in the urine, and she was managed conservatively and she improved clinically. Her swelling improved slightly, but her serum creatinine started to increase and it increased to 2.5 on 15th March, and she was evaluated by the visiting nephrologist at that hospital and was advised injectable steroids for 3 days, but her serum creatinine continued to increase and it increased to 3.5 on 18th March. She was advised kidney biopsy, but she took discharge and came to Sir Gangaram Hospital for further management. In our hospital, she was started on diuretics. She was transfused 1 unit PRBC. She had 1 episode of hematuria on 19th March, which was present throughout the entire duration of micturition and not associated with any burning micturition, colicky flank pain, and there was no history of intake of any drug, any laxative or any food causing red color urine. Patient underwent kidney biopsy on 20th of March. Procedure was uneventful and no hematuria noted post biopsy. She was given IV salmeterol 500 mg post biopsy for 3 days. There was no history of polyuria, nocturia, fatigue. There is no history of weight loss, no history of any recurrent UTI, no history of fever, no history of rash, oral ulcer, hair loss, photosensitivity. There is no history of any drug intake, alternative medication intake. There is no history of fever, cough, throat pain. There is no history of allergy to dust, pollen. There is no history of chest pain, palpitations. There is no history of yellowish discoloration of eyes. There is no history of numbness, tingling sensation of lower limbs, and bluish discoloration of skin, cold intolerance, and any ulceration on skin. There is no history of abnormal body movement, irrelevant talk, no history of hemoptysis or epistaxis. Past history, there is no history of any chronic illness, hypertension, type 2 diabetes. She has history of 2-unit blood transfusion during pregnancy, 1.5 months back. Personal history, normal bowel and bladder habits. Patient is vegetarian. Family history, there is no history of similar complaints in any family first degree relation. Menstrual history, she attained menarche at the age of 14 and her last menstrual period was 9th March. Obstetric history, she married 3 years back. She had one abortion which was induced and one live birth 1.5 years back. She received 2-unit blood transfusion during the pregnancy. Socioeconomic history, according to Kupuswamy scale, she belongs to middle class.
ये कौन सा स्केल है?
Kupuswamy scale use होता है.
Has anyone heard of it?
Yes, ma'am.
You guys are taught this in MD?
Yes, ma'am. It is modified in 2022. In rural population, Uday scale is used, and in urban population, Kupuswamy scale is used.
You've added to my knowledge at least. Okay, you haven't heard of it.
I haven't used it either.
It wasn't taught to us. ये NFHS क्या है? NHFS use करता है. There's this National Family Health Survey.
Yes, ma'am.
They are the ones who give hunger index, ये index, वो index, उसी का part है ये.
मैम ऑफिशियल है मुझे NFHS का.
ओके चल ठीक है.
2022 में लेटेस्ट इसका वो आया हुआ.
मॉडिफिकेशन था. ऑलराइट.
Summary: 33 years old female without any comorbidity presented with generalized swelling of body, which was 2 months back, which was insidious in onset and gradually progressive, not associated with decreased urine output, and joint pains, which involve all the joints, non-associated with any swelling, non-migratory. On evaluation, she was found to have high serum creatinine and leakage of blood and protein in urine, and her serum creatinine increased over next 1 week, over next 10 days to 3.5 gram. She also had one episode of grass hematuria on 19th March. She underwent kidney biopsy on 20th March, which was uneventful.
ना वो तो बता दो क्या है आपका डिफरेंशियल क्या है?
So, my syndromic diagnosis is Rpgn. First etiological diagnosis lupus nephritis class 3, 4, and second is IgA nephropathy, and third is NPGN.
RPGN, SLE, IgA.
RPGN sir, ma'am syndromic etiological lupus nephritis. First, second is IgA nephropathy, third is MPGN.
So is MPGN also an etiology? You have 3 etiologies here: SLE, IgA, and MPGN. So is MPGN an etiology?
Ma'am, it's a it is MPGN ma'am consists of many etiologies.
Yeah, exactly.
Yes,
So
ma'am.
it's not really an etiology. It's as good as saying, let's say,
Immune mediated.
some syndromic,
Yes, ma'am,
whatever.
it is other immune mediated membranopathy of the gene.
Okay. Why do you say RPGN as the first thing?
Ma'am,
Or can it be some other syndromic diagnosis that you would like to call it?
ma'am, I can, ma'am, patient has a history of edema. She has increased creatinine over the period of 10 days, which is, and she has RBCs in the blood, one episode of hematuria, and she also leaking protein. So most likely it is a glomerular pathology. So the point
Can you
is,
call it AKI?
yes, ma'am.
Can you call it AKI?
Ma'am, ma'am, in AKI, onset is within, according to KDICO, AKI is rise in serum creatinine, which have occurred by 1.5 times or 0.3 within 48 hours.
So it's longer than that.
It is longer than that, yes.
What's this new terminology called AKD?
Ma'am, AKI.
It's not new any longer though.
If it persists more than 7 days and continue to then more than 7 days, AKI that persists for more 7 days.
I don't know whether it says 7 days or not. The basic idea of coining this terminology was the gap between AKI and CKD. So CKD you call it 3 months by definition. AKI is like few hours to days, let's say, and in between there was no term. So that was the whole idea of calling it acute kidney disease, which will have overlap this side, overlap that side, and some would recover and get better. So can we call it that?
Ma'am,
I see nothing against it.
Ma'am, it is a.
But Rpgn also is fine, I
guess. It
guess.
is a glomerular pathology. A patient is having microhematuria and it is still progressing. Patient is having symptoms of
Macrohematuria है यहाँ तो gross hematuria हुआ.
हाँ, hematuria भी है. Patient has hematuria, one episode of gross hematuria.
So why do you think this hematuria is glomerular hematuria?
Yes, ma'am.
Why do you think this hematuria was glomerular hematuria? Let's say I argue it came from the bladder. What do you have against it?
Ma'am, since patient has hypertension, history of hypertension, patient has history of prolonged history of edema, which also points to the pathology, renal pathology, and mostly while passing urine, she didn't have any pain, flank pain, or she didn't pass any clots.
If you have to give one reason,
yes,
what would that be to call it glomerular hematuria? Just one reason. One explanation that this is glomerular. Single most important thing.
Ma'am, no, any patient has not passed any clots, micro.
Why?
Any patient has.
So let's say someone comes to you, has either microscopic hematuria or some hematuria. So, or gross hematuria. How do you in your head advise this person, okay, do this, that will tell us it's coming from here or somewhere else? I've narrowed it down for you. Proteinuria. Call it proteinuria. So if someone has proteinuria, it is a definite pointer towards parenchyma, renal parenchyma, and it eliminates the rest, right? So your easiest answer was you said leaking protein in your, what? Leaking protein in urine, yeah. You've said that. So protein in urine rather than idhar udhar beating about the bush. Ajay, ask him something.
So in terms of the differential, I agree Rpgn is on the list, but any other things that you would want to just put out there? Because वो सब बिल्कुल lock in कर जाते हो. I know you already know the pathology. I don't know if you guys have already been shared the potential diagnosis or not.
It went on the your site also.
AKI. There is a possibility of AKI because patient has edema. She was admitted and she received diuretics, maybe some medication, and some drug can also cause AKI due to any interstitial nephritis or anything.
Yeah. So
and she also
AKI, AIN, ATN, okay.
And if patient has nephrotic syndrome, she can have renal vein thrombosis.
Okay.
Possibility of renal. She also there is possibility of any diuretic induced pre-renal. If she have taken, maybe she has taken some painkillers for joint pains, that could cause also AKI. And
so if you were saying nephrotic syndrome with renal failure, what would be the kind of thought process, or what would be the likely combination that you would expect? Someone has severe nephrotic syndrome and you have a creatinine which is 5. So, what would be your likely combination that you would expect that this?
Sir, in our scenario, diabetic DKD is most common cause, secondary, and primary IgA nephropathy, and FSGS.
24-year-old with severe proteinuria, serum albumin is 1.5, and now by the time they come to you, creatinine is 5 also, but they have a 1 week previous creatinine of 1 or 0.8, whatever, take your pick.
Sir, there is possibility of
किस
thrombosis,
renal vein thrombosis तो चलो एक हो गया. Renal vein thrombosis is, that is again, which situation would you suspect renal vein thrombosis? Renal vein thrombosis, membranous with renal vein thrombosis. So that's the classic, but you can have it with other nephrotic syndromes also. But a creatinine of 5 with oliguria or this F. So क्या होता है? Which is the most classic description of which, what if you do the biopsy of them, what would you find? क्रिसेंट नहीं होगा भाई, नेफ्रोटिक सिंड्रोम है.
नेफ्रोटिक सिंड्रोम की बात में अभी 1 था ना, 1 to 5 कैसे हो जाएगा 5 दिन में? मुश्किल है. This, what's the commonest? Exactly.
हाँ? ATN with what? ना डायरेटिक से नहीं हो रहा है, डिजीज से हो रहा है. अभी तक डायरेटिक मिला ही नहीं है उसको.
सबसे अच्छी बीमारी है नेफ्रोलॉजी में.
AIN भी नहीं है, ATN है. ATN है, from the cause of the renal failure is ATN. The cause of the nephrotic syndrome is?
I gave you a hint. This सबसे अच्छी बीमारी nephrology में.
Minimal change.
Minimal change.
So this is classic minimal change disease with ATN. So these are all kind of classic combinations. IgA with gross hematuria. Gross hematuria can cause renal dysfunction, creatinine can go up. Gross hematuria goes away, creatinine comes back to normal. So again, these are classic kind of descriptions that are there, and those are things that you will see. And so if you see it, you know that this is what is going to happen. You can tell the patient. If you've already had a biopsy and they were minimal change, and now their creatinine has gone to 5, you know that this will come back. So you can be rest assured, you don't need to do another biopsy to look for it, because you know this is minimal change. They are severely nephrotic. Usually classic will be the serum albumin will be 2 or below, and they are just severely nephrotic. And you give them time, you give them the steroids, and they will come back. So you don't then have to kind of go looking for new things. So that's kind of something. Okay. So in terms of the history was just, I'm going to now do a little nitpicking on the history and how you presented it, just for everyone's kind of how you present and kind of what things you say. So you said the history was taken from the husband, not from the patient.
Sir, actually she was not giving history properly at that time.
Okay.
And, she was very distressed, and she was not cooperating at that time.
So she's been through a lot, she didn't want to, so you said the history was from the husband. So, but then every place, the way you presented it, it was as if she was the one who gave you the history. So then if the presentation is from the husband, then we need to also, during the rest of the story, have the story be presented as if it's coming from the husband rather than from her itself, because the rest of it was another word which whenever I hear it, I really kind of
Frothuria.
Frothuria is one. मेरे को उससे ज़्यादा है.
किससे परेशानी?
Treated conservatively. I'm not sure what that means. So when you say patient was treated conservatively, what was the aggressive option that they decided not to take? So again, this is something which is not just here. It is everywhere. It's everywhere. Everyone writes in their discharge summaries as well as in their notes, patient was treated conservatively. What was the aggressive option that you offered to the patient that the family and the patient said, no, we don't want this aggressive option, give me the conservative option? Was there an aggressive option? Was there a treatment option that you were offering to the patient? If the treatment option that you offered was, let's do diuretics, that's fine. Diuretics can be aggressive also. You can put them on a drip. You can give 30 mg per hour. That's aggressive diuresis. You can dialyze someone and dialyze them off. But many times people will use that word, and that really, I don't know, it kind of really just gets me off. So
I
be
think become
careful.
cultural / training. I don't know.
So,
Yeah, it
so
goes
I
on.
would, I would encourage
I
you
don't
not to
understand
use
it.
that word unless it is actually something that is offered to the patient and then changes.
Or I would say the treatment is definitively surgical, and then you don't do it, then that's conservative.
Yes.
I think that's how I would take it. कि
कैंसर
appendectomy करने की जगह उसको बैठाए रखा
कैंसर था सर्जिकल कैंसर था सर्जिकल ऑप्शन ऑफर किया दे डिसाइडेड नॉट टू गो फॉर सर्जरी एंड दे आर नाउ डूइंग कंजर्वेटिव केयर or palliative care or comfort care. That is where I would use it.
So I think that's where I would draw a line.
So that kind of just, and then again, a lot of times people use the word urine output was normal. I'm not sure what that means either. What is a normal urine output? You can say patient did not report any oliguria, patient did not report any anuria, but what is normal urine output? They have, you're describing swelling. That means that the urine output is not matching the input, which is why they have swelling. So again, the patient might report it, but when you are describing it to the rest of us, that really doesn't. So what you want to say is there was no oliguria or anuria. So say that there has not been any history of oliguria or anuria in the past, there hasn't been any hematuria, but when you say urine output is normal, then that means very little for us when we are looking at it. So again, words to be a little careful with or use with caution. So I think that's kind of all.
Now that we are on history, so you began 2 months of whatever history.
Yes.
Then at some point she gets admitted at Noida, and on 19th March she comes to you. So if you are describing an admission, at least you could either go date wise, the previous Noida admission could have a date and a discharge date, or at least give us a duration, which gives us some sense how long was she in that hospital. At least the duration I would say is important. Let's say 1 week, 2 days, 10 days, 45 days. So in this broad spectrum of 2 months, we have no idea when did she go to hospital, after 15 days of sickness, after 30 days of sickness, after 45 days of sickness. So I think a time frame would be better. It defines it better. The other thing which I keep telling my fellows is, somewhere they start like the previous one who presented here, some pregnancy and chronic kidney disease, you guys would know. So he was going back and forth with some years and pregnancy weeks. So maintain the similar chronology, like 2 years ago or with the weeks of pregnancy, suddenly date आ जाती है बीच में and you lose track कि अब इस date को कितनी pregnancy है मुझे क्या पता. So you have to kind of organize things in your head and make it so that it's to the person who's hearing it, he can comprehend it. That's the whole idea of organizing the history. Chalo.
So, exam.
On examination, patient was conscious, cooperative, oriented to time, place and person. Patient was afebrile. Her blood pressure was 140/80 in right arm and supine position, and blood pressure was equal in all the 4 limbs. Her pulse was 83 minutes, regular, normal volume. The condition of vessel was normal, no radial or no radiofemoral delay, and all peripheral pulses were palpable. And hair was normal. There was no lateral thinning of eyebrows. There were no rash on the face. There was no rash on the face. JVP was not raised. There was no oral ulcers. Her oral dental hygiene was satisfactory, and their trachea was centrally placed. There is no thyromegaly. There is no no edema. There was edema pitting present up to the knee. There is no clubbing, no lymphadenopathy. Nails normal. There is no rash over the body. There is no joint tenderness. No xanthelasma. Air, nose. There is.
Give us the relevant stuff here.
Yes, ma'am.
Just give us relevant
Positive.
stuff, either positive or negative, which you think is important. Positive
Ma'am,
obviously becomes important, but any negative which you think is
only
important.
Positive history is edema and pallor. The relevance of oral ulcers to
Okay.
rule out lupus, ELT discharge to rule out any vasculitis, and rash to rule out any vasculitis, and nail changes. There is to look for any nail involvement, splinter hemorrhages, any changes related to anemia. There is any, if there is any Merkey's line due to hypoalbuminemia or any.
Okay.
Systemic examination, ma'am, respiratory examination was normal. There was no crackles. CV examination is also normal, and CNS also she was also normal.
Okay. So, is there any change in your set of diagnoses now? Remains Rpgn, SLE, IgA. What will you do further? How will you manage her further?
Yes, ma'am.
किसी और को कोई और डिफरेंशियल में ऐड करना है किसी और any other possibilities that link up with swelling, anemia, thrombocytopenia, renal failure, hypertension, any other differentials that people want to add? एक और ऐड कर देता हूँ, altered mental status, TTP, TMA. So again, you can have rapidly failing with anemia and thrombocytopenia. So that would be another one. Right? Again, someone hypertension, renal failure, swelling, edema. So that can be another one. Okay. So now, how would you evaluate and manage?
So first we'll take detailed history of the patient.
तो ले ली भाई, ले ली, दे दी, ले लिया, दे दिया.
Complete blood count with peripheral blood smear to look for any TLC counts if there is any leukopenia, thrombocytopenia, and PVF to look for any schistocytes, and then do the KFTs to look for serum creatinine values, sodium, potassium, electrolytes, calcium and phosphates, and urine analysis to look for any protein hypohematuria.
So urine analysis किया था आपने?
Yes, sir.
आपने खुद किया था? क्या दिखा?
वो खुद किया था?
मैम मतलब बाद में किया था जब देखा था डिपस्टिक किया था.
नहीं डिपस्टिक की बात नहीं कर रहा.
डिपस्टिक कौन करता है?
हमने भी किया था यहाँ.
हाँ सेडिमेंट देखा था.
सेडिमेंट ही देखना होता है, डिपस्टिक तो खैर वो टेक्नीशियन ही कर देता है.
सर उस यूरिन में RBCs जो
Oh, see again, this is now a yes and no answer. Did you spin the urine and have a look of the sediment on the slide? Yes or no? हाँ, बस सीधे सीधे बोलो. अब कहानी में घुस जाओगे, लेफ्ट राइट घाट चले जाओगे तो फिर पिटाई हो जाएगी, है ना? So it's a yes and no answer. Answer yes and no. If someone is asking, did you look at the urine? If you looked at it, say yes. If you didn't, say no. Say we have the dipstick report.
कितने साल हो? Which year are you?
सेकंड ईयर थर्ड ईयर स्टार्ट हो
2 साल कंप्लीट हो गए. Have you done any microscopic examinations? स्पिन करके अपने आप आज तक आप लोगों में से किसी ने किया? Anyone has done urine microscopic examination on his or her own? Nobody.
That's a shame.
कुछ तो कर लो यार.
That's a shame. So again, I would say
रोज करने की जरूरत नहीं है.
Exactly. There are 2 or 3 that you can do, and you will see. And then once you've seen them, you will say, "I want to do it on my own for certain cases, not for this or exam, but for answering the patient that is in front of you. So again, 2 or 3 where it is crystal clear will be one. As ma'am was saying, there is someone who has hematuria and you are not sure whether this is glomerular or not. There is not significant proteinuria. So then you spin it, you look at it, you see the acanthocytes, you know it is glomerular. You don't need to then go getting all this other stuff. The other is ATNs. Someone comes in, they have renal failure, you spin, you will see muddy browns, and then you're done. You know this is ATN. Or you will see significant kind of granular casts which are also kind of ATN, but depending on where the spectrum is on the ATN. And you will know this is ATN. You don't then need to go looking for why did this person get into renal failure. You know it. And so again, they will actually help you take care of the patient in front of you, where you're still figuring out what happened, why it happened, and you will then do it. So 2-3 होंगे, ATN तो बहुत अच्छे से दिख जाता है, फोली में भी ब्राउन ब्राउन आपको डिपॉजिट दिख रहा है, उस वाले का एक लेके देख लो, भर भर के मडी ब्राउन होंगे. ATN तो हर किसी के ICU में 2-3 का पकड़ लो, 1-2 का देख लोगे, you will have enough ATNs to kind of remember for the rest of your life. And then glomerular hematuриas. Take a few of them, take a lupus patient currently active and have a spin. You will have a full house urine, or take a IgA with some microscopic hematuria and spin and see acanthocytes. I think utna to go.
It's like a video class, I think. You never get to see a real. दो चार तो देख लो कम से कम.
I think that's.
2-4 देख लो. रोज रोज करने को कोई नहीं बोल रहा. एटलीस्ट एक WBC कास्ट देखनी आनी चाहिए, एक RBC कास्ट आनी चाहिए, एक मडी ब्राउन आनी चाहिए. नहीं तो वो हर डॉट उसमें RBC लगता है यूरिन में, unless you have seen it. I'm telling you, every dot you will feel ये RBC है, WBC है, unless you have seen it. Please do it. Okay.
Doesn't take long, and again you can use the technicians.
Let them spin it.
They will be super duper happy to have a doctor come in and look at it. You can tell them, they'll keep it ready, they'll have the cover slips, they'll have everything, and you can look at it. They'll focus it for you also. so उसमें भी problem नहीं है.
No, there are few things in life which you need to do. Like you can't drive a car unless you've driven it. जितना 1000 वीडियो देख लो, urine microscopic is like that. Dipstick has no meaning. Dipstick तो कोई भी कर देगा. एक सेकंड नापना है, एक डालना है, निकालना है. But this is something you need to see. Dipstick में भी कभी कोई मरीज पूछ लेता है, बड़ी दिक्कत होती है, खुद को करना नहीं आता. So, but
and आजकल की automated machines can pick and put in lots of wrong stuff also. It's automated pick हो रहा है.
Everything
and
is
technician वहाँ बैठ के उसको okay कर रहा है. That is how it is. कि किसी के भी यूरिन डिपस्टिक में आजकल लाल या किसी का देखो तो 200 आइटम है, वो 200 आइटम में कंप्यूटर ने पिक किया है, टेक्नीशियन ने ओके क्लिक करना है. So that's how it's actually being done. So when it says calcium oxalate crystal or a granular cast or this cast or that cast that is on the report, it's a technician saying okay to a computer that has read it. So that's kind of what it is. So whether you can trust it or not is dependent on the eye of the technician.
And sometimes it's not only daily routine which we are stressing about. Some examiners will ask you what speed you would spin the centrifuge if you have put tubes in the centrifuge. डाली है कभी? नहीं डाली ना. Centrifuge देखा है कभी? नहीं देखा. लग रहा है. डाल लो. एक बार कर लो. चलो ठीक है, आगे चलते हैं.
Yes. So CBC, KFT urine.
Urine will look for RBCs, WBCs, casts, WBC cast, RBCs cast, and where is where.
So okay, tell us what would you expect in each investigation in this patient maybe? Theoretically हम सबको पता है कि क्या देखना है. So what is this person likely to have?
Leukopenia can be seen. Thrombocytopenia can be seen.
Okay, if you found a low TLC and a low platelet count, does it select any of your etiologies?
Ma'am, in lupus nephritis.
Okay, it takes you towards SLE. Okay, next. Urine, what do you expect to see?
RBCs, cast, RBCs, WBCs cast, RBC protein.
Why WBC cast?
WBC cast can be seen in lupus nephritis, and it is more specific as compared.
It's more specific for lupus.
No, it is. It is.
Why?
No, WBC cast can be seen.
Okay, what does WBC cast tell you?
Ma'am, WBC.
Where is the disease in WBC cast versus RBC cast?
Ma'am, RBC cast. Ma'am, there are damaged erythrocytes that in distal tubule. They.
The answer was very short. Where is the disease if you find RBC cast?
Ma'am, it is.
Where is the disease if you find WBC
RBC
cast?
cast. It is mostly seen in proliferative glomerulonephritis.
Okay, somebody who has glomerular hematuria or a glomerular disease, then the answer is glomerular disease and one phrase, let's say.
Yes, ma'am.
And WBC cast, where is the disease?
And tubular involvement is there.
Okay, good. So that should be very clear in your head, right?
So, in one of these diseases you said you are going to get glomerular hematuria and RBC cast. In another one you are going to get both RBCs and WBCs. Why is the difference? Why would you expect there to be a difference? So, or which one is what, and then why would you expect the difference? So, you right now you have two main differentials,
SLE
and IgA,
correct.
right? And in one there is glomerular hematuria and RBC cast. In the other you have glomerular hematuria, RBC cast, and you have WBC cast. That's what you said, because WBC's casts are specific for lupus. I got you right, in terms of what you said. That WBC
he kind
cast,
of said WBC cast.
WBC cast are also seen.
Yes,
Right.
WBC casts are also seen. So why?
You are right.
Yeah,
You are right. We are not disputing that.
So
Nephropathy, WBC cast are not.
are not there. Absolutely.
Correct.
So I agree with that also. So why is that difference? So why? So again, you can broaden the discussion to why are there certain glomerular diseases in which you only see RBC casts, and why are there certain glomerular diseases in which you see RBC casts and WBC casts?
both.
So what's the difference between the two, and why do you see it in one and not in the other?
Or
and
you
why
can
don't
give
you
us
see
which diseases and you would know the answer.
And we can broaden it to, let's say, why in nephrotic syndrome do you not see any of those? So you have, these are nephritic syndromes, Rpgns, IgA, lupus, and then you have nephrotic syndromes. So in nephrotic syndromes, you don't expect to see any active sediment, you don't expect glomerular hematuria, you don't expect pyuria or WBC casts. While in nephritic, there are certain that have RBC, certain that have WBC, and certain that have both. So how and why is that difference?
Anyone
there?
else can also answer.
Because
Please
this
come
is
along.
open.
This is open discussion. He is at a loss, so
And
कोई भी आ जाओ इधर से. Anybody volunteer.
तो पहले सबसे आसान, नेफ्रोटिक सिंड्रोम में आरबीसीज एंड डब्ल्यूबीसी क्यों नहीं दिखते? पोडोसाइट एफेसमेंट है,
कहाँ पहुंच गए?
पोडोसाइट एफेसमेंट से प्रोटीन लीक हो रहा है, राइट? दैट इज द मैकेनिज्म. यू हैव पोडोसाइट एफेसमेंट, प्रोटीन लीक हो रहा है. आईजीए में भी, लूपस में भी प्रोटीन्यूरिया का मैकेनिज्म तो पोडोसाइट एफेसमेंट है, फोकल है, सो वो है, मिनिमल चेंज है या प्राइमरी एफएसजीएस है तो full effacement hai. That's the only difference. So that's the explanation for proteinuria. Glomerular hematuria kyun hota hai? Okay, so now you are talking capillary endothelium. Breached to baad mein baat karenge. So capillary endothelium. What is it that is going on that is now going to cause pyuria? And which are the diseases in which you get WBC casts? And where are the deposits? So again, now we are talking different deposits. So you have endothelial deposits, you have membranous deposits, and then you have epithelial deposits. And the location of the deposits is what determines what kind of inflammation is going to get triggered in the glomerulus. That is going to dictate what kind of outcome you are going to see. So, if you have epi deposits, that is when WBCs are going to start interacting. If you have only endo, there are going to be RBCs as well, but you can have RBCs you have in IgA also. There you have mesangial, paramesangial deposits, and that is where you. So, depending on what you are going to get interacted, and inside the membrane there is no inflammation. So, which is why in membranous the deposit is inside the membrane, it is not subendo, it is not epithelial, there is no interaction, which is why you do not get hematuria with membranous, because those are inside, there is no inflammation that is happening. And minimal change and FSGS, you do not have any deposits at all. So, there is no inflammatory response. So, it is based on what kind of inflammatory response and where your deposits are, that will determine. In lupus you have everything, so you get all of it. ठीक है, चलो ये तो यूरिन पे फंस गए.
हाँ, यूरिन पे फंस गए.
ठीक है, CBC, KFT, urine. Then what else do you want? Or
Sir, 24
want
hour,
it?
yes, quantification of urine, 24-hour urinary protein quantification.
24-hour urine protein. Okay. So is that something that you recommend for each patient all the time?
No, sir. If patient is having nephrotic syndrome.
Okay. Is patient may you want a 24-hour urine collection?
Not necessarily, sir. If patient is having gross hematuria and proteinuria swelling.
You do want a quantification. So how would you quantify it?
Sir, first in 7 a.m. in early morning, first urine is voided and then patient is asked to.
No, he is not asking you that. How would you quantify this woman's?
So you want to order a
proteinuria?
test, you are ordering the test. What test would you want to order?
So we can we can order in adults. Usually urine AC ratio is recommended.
Okay.
Or 24-hour urinary protein is the gold standard test.
So you said urine ACR
Yes, sir.
versus 24-hour, and in the 24-hour urine you are now measuring protein, not albumin.
Yes, sir.
Okay. Any other test that you have an option of between
Urine
these
PC
two?
ratio, urine protein creatinine ratio.
Urine protein creatinine ratio. So now, how are you going to determine which one do you want to order for which patient?
Sir, usually category recommends AC ratio. 24-hour urinary protein is the gold standard, but in children, urine PC
What are the
ratio.
fallacies of a 24-hour collection?
Sir, it is very cumbersome. There is a risk of underestimation of urine, under collection of urine or over collection.
How do you try to beat that?
So we ask the patient to void first morning urine sample.
That method, I think, is.
नहीं 24-hour urine
How-
में कौन सा first void का है?
7 a.m. first void.
She's
first
telling how to
normal-
collect 24
हाँ,
hours
नहीं,
urine.
24-hour का तो you
चलो,
told how to
ठीक से
collect
collect कर लिया.
कर लिया उसने अपनी
But
तरफ
how
से.
do you beat it?
How do you confirm that this was actually a 24-hour urine collection
Yeah.
and not 30 hours and not 20 hours? Creatinine clearance, okay. That is
That's the
a
next track
very different way. So,
One person. बोलो दोबारा बोल दो.
okay.
Good.
So, yes. So,
That's
that is a
better.
very different, creatinine clearance is very different than a 24-hour urine creatinine excretion. And so, what are you looking for in that? What would you be, so let's say there is someone who's done a 24-hour urine collection, the protein is 6 grams and the creatinine comes out as, let's say, 800 milligrams. So, is that a good collection, an under collection, an over collection?
बोलो जोर से बोलो.
Measured should be at least 50% of the estimated GFR.
Oh,
Who's measuring
ये
GFR?
कौन सा
We don't
GFR?
even have a serum creatinine
अभी तो
to measure.
चलो सीरम क्रिएटिनिन भी दे देते हैं, इसी का ले लेते हैं. 3.5 का सीरम क्रिएटिनिन है. That's a different discussion that we can get to what that means. But So let's say someone has a normal kidney function right now. Before
अभी
we get to
normal
a
की बात
creatinine
हो रही है.
let's start with a normal and then we'll get to a creatinine of 3.5 and what that means. So if someone has a normal creatinine, creatinine's 1.
So what does 800 mean? Let's say it's
800
mine
milligrams.
and I have a normal kidney function.
Creatinine is 0.8, 800 mg, 24-hour urine creatinine excretion, and 6 grams urine protein. So, and I give 6 grams and I give 2000 milligrams of creatinine. So what does that mean? So I have a 24-hour, ma'am has done a 24-hour urine, 6 grams protein, 800 milligrams urine creatinine excretion. I give 6 grams and I give 2 grams of urine creatinine, 2000 milligrams of urine creatinine. So what does that mean? Both. Answer भी दे रहे हो.
जोर से नहीं बोला.
Modality in male there is high more muscle mass.
More muscle mass. कितना muscle mass? मैम ने मेरे को माइक टाइसन बना दिया.
हाँ, exactly. 2000 कहोगे तो माइक टाइसन बन जाएगा ना.
सीरम क्रिएटिनिन की तो बात ही नहीं हो रही है. अभी हमने सीरम नापा ही नहीं है.
यूरिन क्रिएटिनिन इज मोर इन लेस इन डायल्यूटेड.
क्या होता है? कोई हिसाब किताब सिखाया जाता है. वो हिसाब किताब क्या है?
Yes.
सीधी सी बात है यार. There is some हिसाब किताब which is taught to every fellow in first year.
Should be that how do you evaluate
15 to 20 mg per kg.
Yes.
Good.
Exactly. So
25 mg per kg.
yes. So मेरा वेट लग रहा है कि मैं 2 ग्राम निकाल सकता हूँ, है ना. बॉल पार्क भी लगाओगे तो 70 ही बन रहा है. So 70 का कितना बनाओगे? 15 to 20, 20 में 1400 आएगा, 15 में 1000 आएगा, है ना. So that is what you would expect. So if I have given a 2000 milligram, it's an over collection, right? If ma'am has given 800, might be okay, might be slightly under. Right, so that is what is how you do it and say yes, this is an okay collection, this is an under collection, or this is an over collection. You correct it for creatinine and how much creatinine per kilogram of body weight they have put out, and there is a range and you want it to be within that range. Now someone has AKI and their creatinine is gone from 2.5 to 3.5 in 3 days as he has, and he has now ordered a 24-hour urine collection on this. So now how would you evaluate that urine collection? So this 24-hour urine collection comes back at 6 grams and 500 milligrams. So is this over, under, or correct?
Overestimation, because patient has less creatinine clearance.
Over, less, okay. So 500 milligrams है, weight तो उसका मैंने लगा दिया 60 kgs. So उसमें आएगा, इनका calculation लगाओगे तो under आएगा, 15 mg per kg भी नहीं है. So is that correct? Is that a 24-hour clearance or is that no?
So because patient's serum creatinine has increased, it is AKI, so urine creatinine clearance has decreased, so there should be decrease in the creatinine in urine volume.
Absolutely. So there should be a decrease. So in this situation, that 15 to 20 would not apply. So the 24-hour urine collection that you've had could be accurate, and that is the amount that they have actually, 6 grams is what they have actually lost. That is what has actually come out in the urine, because this could be lower. Similarly, if you do a spot urine creatinine. So now if you do a spot urine protein creatinine in someone who has AKI, how do you estimate it? So what is the assumption when we do a spot urine protein creatinine ratio? What is the assumption when you say spot urine protein creatinine is, let's say 5.5. So you do a spot urine protein creatinine ratio, the ratio comes out at 5.5. So what do you assume is the 24-hour protein that they are excreting in a day? That many grams. Why? Why is it that many grams? What's the underlying assumption?
That 1 gram creatinine is excreted
By everyone every day.
Exactly.
So that is the underlying assumption, that everyone, whether it is her, whether it is me, whether it is him, or whether it is any adult, that the underlying assumption when we use a spot urine protein creatinine ratio is that the creatinine excretion of everyone is 1 gram. So that is the problem with the spot, that it is assuming everyone, whether it is Mike Tyson or whether it is one of us, their creatinine excretion in 1 day should be 1 gram. And so if you multiply it by 5, If someone has AKI, you have a problem, creatinine excretion is lower, the ratio will likely be artificially higher, right. Similarly, if they have high muscle mass, they are putting out more creatinine, ratio will be artificially lower. They are thin person, low creatinine excretion, ratio might be higher than the actual 24-hour excretion. So those are the fallacies.
So that's the reason KDO recommends 24 hours as the first test. And if you have to follow it up, even ratios are fine. But if you think realistically, it's very difficult to do a 24 hours. And how much is your management going to change between, let's say, 6 and 8 grams of proteinuria? Management remains the same. Or let's say, and it's the serial one in many diseases, that is important rather than just one figure. So that's why you can be pragmatic. And everyday life, I rarely order a 24 hours urine protein, rarely ever.
I also, very rarely.
Yeah, so just because it's convenient, if you had to collect it, you won't like it.
24-hour urine is only donors, pre-workup for donors. That's where we do 24-hour collections, otherwise most
So
other
it's a
people-
difficult thing to do, nobody wants to do it, right? Ideal, we agree with you, but cumbersome.
In this situation,
And then you should know this background,
Yes.
which we harped about.
and in this, would you order a UACR or would you order a urine protein creatinine ratio? Last part of this.
Sir, I will order urine AC ratio.
Okay, why?
Sir, her presentation is of glomerulonephritis. So
What range of protein are you expecting for her to be leaking? What ACR ratio? What ratio are you expecting? Is it going to be in the 30 milligram per gram, 300 milligram per gram, 3 gram per gram? What range are you expecting the UACR to be in?
around 2 gram near to.
So somewhere between, let's say, 1 to 5 grams. Your urine albumin, what kit are they using and what range does the urine albumin kit have? So एक बारी check करना. So the problem when you are ordering it, the urine albumin kit is
They
predominantly
do a semi-quantitative.
and it's predominantly ranged for the lower end of
300.
the spectrum because it's meant for diabetic microalbuminuria detection. It is not meant for your high end range of proteinuria. So it's not built for it. So if you have someone who you're expecting to be proteinuric, you're better off with the urine protein creatinine ratio than the urine ACR. ACR is very good at differentiating between micro 30 to 300, 300 and above. It's going to be much better there. If you're in the 1, 2, 3 gram range, your urine protein ratio is going to be better.
So some labs, this is how our lab used to give us the report, just to let you know. So there was a creatinine number, so many milligrams per dl, and the albumin came as greater than 114 something something, whatever the unit was. So yeah, milligram per whatever deciliter or whatever. So above 114 is endless, whether it's 10 gram, 5 gram. So when I joined this hospital, I got the protein also added to that report. So I told them, whenever it's above this ratio that you can't measure, please do a protein estimation in the same urine sample and give us the protein as well. Now life is simpler. So now our report comes as creatinine more than 114 something, and then there is like 1000 whatever, 7000 milligram per dl, something like that. So I can now calculate a UPCR whenever I want.
And again, so if you go to AIMS, I think AIMS has also done this. So if their UACR is beyond their range, they will automatically default to a UPCR and give you a UPCR value in their report. So I've seen a couple of reports from AIMS with patients where the order was for a UACR, the urine albumin was very high above their range. So they decided not to do the UACR, they did a UPCR and they reported the UPCR. So I think that's something which can be done, but again,
And
not
just
all
check
labs
your
are doing
reports,
it.
maybe yours are also given like that.
No,
This
no.
is what
Majority
I got
labs
done.
Are not, majority labs are not doing
This
that.
is what I got
Majority
done in
labs
my hospital at least,
They will
at
dilute
some
the
point.
sample. They will dilute the sample.
वो dilutions
tenfold,
भी लिखा होता है.
dilute, and then they will report by recalculating the diluted sample up. So usually that's what the lab will do. They'll dilute it back into what they think is in their reasonable range and then report it that way.
And I don't know how many reports, every lab reports it differently. And somewhere
cross-check the
one
multiplication.
number would be milligram per DL, the other one may be milligram per liter.
Yeah.
And you have to wreck your brain and change the
And
units to same
Many times
ones.
their calculations are wrong.
Exactly. So do
you
it
will
yourself.
have to check them. Sometimes, just like ma'am said, they are just dividing milligrams per liter by milligram per deciliter and getting a humongous number where
Exactly.
their number is actually wrong. And if you just put it back into DL, there isn't actually significant proteinuria, because these are auto calculated. Once set, it is auto being released. So I've had a couple of labs where I've had
And something
told
would be
patients, but
written in
they haven't corrected it.
micrograms, something in milligrams. You have to kind of put them all in the same units and then get a ratio. So learn to do it yourself.
and
Okay,
cross-check
if you
the
haven't
units.
done it, please look at these reports in detail and do it.
Okay. So CBC, KFT, urine, UACR, UPCR or 24-hour urine.
PBF.
What else?
So in CBC we also look for PBF, तो बताया cystocyte index और
ठीक है. For TMA, TTP or any AIHA, that's fine. What else?
Sir, then we will do C3, C4 levels,
Okay.
complement levels, and do ESR to look for vasculitis, autoimmune markers, ANA by IF, or the ANCA, C-ANCA, C-ANCA and P-ANCA.
Hey, you didn't say vasculitis, the ANCA vasculitis in your differential. I suddenly remembered when he said ANCA. Why not?
नहीं खाली वो नहीं है.
That could be a possibility,
So if we are talking crescentic, Rpgn is crescentic
Rpgn.
GN. Crescentic GN में how would you divide the crescentic GNs?
If you get 100 crescentic GNs, what would be the breakup?
Or just
That's the
differential.
question given in an easy format.
Percentage.
No precise percentage, but
Yeah, just
big zones.
hello, hi boss.
Most common crescentic.
नहीं मैं
Crescentic
एक lecture
GNs,
में
you
आया
have
हूँ,
100
sorry,
patients
meeting में था.
on
हाँ,
biopsy.
बता.
So, commonest.
Commonest is P-ANCA, MP3, P-ANCA.
Commonest would be, let's say, ANCA associated. P, C की तो बाद में बात
भी आ गया,
करेंगे.
मैम ने भी देखा.
And it also depends on the age group. 33-year-old woman,
हीमाटोमा ही है, तो evacuate
I
करना
still may
है,
say
तो फिर
SLE.
open करके देख लेते
but
हैं, नहीं तो फिर रहने
yeah,
देते हैं.
okay, ANCA.
जैसे
ANCA
अब-
associated vasculitis, just
ठीक
call it that.
हाँ हाँ ठीक है
Second,
ठीक है ठीक है डन डन डन. मैंने कहा एक बार वही
Usual
just आपके
50-60
साथ
year
run through
age
करना
group,
था.
that's where-
So that was the only thing. ठीक है ठीक है.
how common is NT-GBM?
It's very rare. 1 in a million. IgA with crescentic transformation, IgA nephropathy.
As a part of 100 crescentic GNs, I would put it somewhere on the floor.
Lupus can have also crescentic.
Use a broad term, immune complex.
Immune complex mediated.
IRGN types.
IRGN.
So, commonest would be ANCA, second commonest would be IRGN, and then you get NT-GBM, maybe 10-15% approximate, maybe even less than that.
So again means so I would, ma'am is right, but I would put it in some kind of format. So you either put it in a IF format and say in immunofluorescence, you see a crescentic GN, you have a biopsy, you'll ask a pathologist, what did IF show? Right? That's the
Yeah,
next
you could-
question.
that
That's
could be the next thing.
That's the next question that you should be asking. So on your IF, it's going to be linear, post-immune, linear or granular. If it's granular, it's going to be immune complex. Post-immune, it's ANCA. Linear, it's anti-GBM. It's immune complex. Then inside immune complex, what's the immune complex? Full house, IgA, or only complements. So that kind of then breaks it down. So you will need to, otherwise you start open forum, then you are going all over the place. So you need to at least have some kind of system by which you are trying to break it down. Otherwise, it will become very difficult. So for crescentic, you have the GN, it's a path diagnosis. Rpgn is a clinical diagnosis. Then you have to keep your eyes open and not just label it only crescentic. You can have other causes of rapidly progressive renal failure. GN makes you fix only on GN, but if it's a clinical diagnosis, then keep your options open and then you open up everything. So अब हम आ गए ANA एंका,
ANA एंकास हो गए, ल्यूपस हो गया,
C3C4 हो गया, ठीक है, ठीक है. अब क्रायो कह रहा हूँ, क्रायो तो सॉरी,
क्रायो तो बता चुका है,
हाँ?
क्रायो तो बता चुका है.
नहीं नहीं. So लो कॉम्प्लीमेंट डिजीजेस कौन कौन से हैं फिर?
That's another way to look
Another
at
way
it.
of looking at it. So if you have low complements, which are the GNs that have low complements?
Sir, lupus nephritis, IRGN, immune infection related glomerulonephritis, and C3G, MPGN in MPGN, C3G, PGMID,
PGNMID.
PGNMID, C3GN, lupus nephritis, HUS, नहीं,
C3 नेफ्रोपैथी आपने बोल दिया ना.
C3 nephropathy. And,
वो भी अल्टीमेटली तो MPGN वाले उसमें आएगा, बट
No, but just to think about it, ठीक है.
Okay. So 4: cryo, lupus, infection, and MPGN.
IRGN.
ठीक है. So those are the 4. So again, break it down, have your groups to simplify it. ठीक है. Okay. So C3C4, ANA, ANCA. Anything else that you would want?
LDH levels to
Okay. LDH.
So coagulation INR APTT can be done.
Can भी नहीं, बायोप्सी अब तो यहाँ हो
बायोप्सी
चुकी है,
करनी
नहीं
है तो करना ही
वैसे
है.
हाँ,
INR
बायोप्सी का
ठीक है,
प्रीरिक्विजिट तो है ही
ठीक
है.
And then what else? What else is on your differential? So you've had 3, we've added a few for you.
So we can also do extractable and nuclear antigen profile.
अभी तो ANA की रिपोर्ट तो आने दे, फिर कर लेंगे. So but बाकी other things on your differential, we had post infectious, anything you would want to do for that?
Yes, so
you had MPGN, anything you would want to do for
The
that?
post infectious की possibility ASO titers and
Anything for MPGN?
C3C4.
What are common causes for MPGNs that you can check by blood tests?
Hepatitis B, C, yes sir. Hepatitis B,
Viral markers?
C, HIV.
ठीक है, ठीक है. ओके. सो अब इसमें क्या क्या आ गया वो भी बता दो फिर.
हाँ, और क्या.
So
We can
what are the reports and then
talk
we'll
about the biopsy
biopsies.
then maybe.
Yes.
So initially patient का ANA positive था.
Initially positive था,
और बाद में
मतलब
negative हो गया.
finally negative हो गया.
नहीं जब ANA positive आया था पेशेंट का पर DDS से DNA एंटीस्मिथ नेगेटिव एंटीबॉडीज नेगेटिव थी.
ठीक है.
पेशेंट
ANA positive था तो कितना positive था? When you say positive, what titer are we talking?
1:160.
160.
1:160. Okay.
एंटी पेशेंट का ENA प्रोफाइल में एंटी रो और LA पॉजिटिव था.
Okay.
पेशेंट का सर पेशेंट की पेशेंट का जो प्लेटलेट्स काउंट्स 30,000 सॉरी प्लेटलेट काउंट्स इनिशियली 80,000 थे और पेशेंट की बायोप्सी में क्रायोग्लोबुलिन वेस्कुलाइटिस.
वो तो बात की बात करते हैं ना, देखो
एक एक करके करेंगे ना. So
एक एक
अब
करके.
उसके अलावा सर इसका C3 लेवल्स और C4 लेवल डिक्रीज थे.
ठीक है.
DNA पॉजिटिव था और एंटी रो और एंटी LA एंटीबॉडीज पॉजिटिव थी.
ठीक है. एंका नेगेटिव था, ASO नेगेटिव
बाकी
था,
सारे टेस्ट इनके नेगेटिव्स थे।
ठीक है। एंड CBC में आप पेरिफेरल स्मेयर में कह रहे हो
कुछ नहीं था।
पेरिफेरल स्मेयर वाज ओके बट
Initially it was-
थ्रोम्बोसाइटोपिनिया था।
हाँ, थ्रोम्बोसाइटोपेनिया
80,000 you said, na, which fell down to 30,000 then.
वो बाद में हुए थे पोस्ट।
ठीक है।
इनिशियली इट वाज।
ठीक है।
So can you narrow down after this? लग नहीं रहा वैसे। DNA is awaited, anti-DS-DNA at this point.
DSDNA and
was
Smith are
negative.
negative. ठीक है। DSDNA and Smith are
Smith are
negative.
negative.
ANA is positive. ROLA is positive. C3, C4 is low, and thrombocytopenia is also now happening. In addition to this, so with this information, what would be your differential or your likely diagnosis?
So there is possibility of immune complex mediated glomerulonephritis. Most likely lupus nephritis is still first possibility.
Okay.
So other
So अब देखो जब उल्टे डायरेक्शन से करते हो ना तो फिर फंस जाते हो। सो RPGN में आपने लूपस डाल दिया, अब कह रहे हो इम्यून कॉम्प्लेक्स जीएन जिसमें से लूपस प्राइमरी है। उस समय अगर क्रिसेंटिक, पॉसी इम्यून, एंटी GBM, इम्यून कॉम्प्लेक्स, इनसाइड इम्यून कॉम्प्लेक्स, लूपस, IgA, पोस्ट इन्फेक्शियस, so if you start with that structure you can still maintain that structure throughout the presentation, versus you jump into and latch into one and then you start having to come back. So keep everything open, start with the same structure everywhere and it will be easier. So okay, so now likely immune complex with lupus as first, ठीक है, and then you have your biopsy. So what does the biopsy show?
So biopsy में ग्लासी eosinophilic intense pass positive
पूरा पढ़ो ना,
से biopsy
ग्लॉम्स में क्या चल रहा है?
पूरा पढ़ो ना, ग्लॉम्स, इंटरस्टिशियम, वेसल्स,
मैम
वैसे जाओ।
ग्लोम्स 34 ग्लोम्स थे, नो सेगमेंटल और नो ग्लोबल glomerulosclerosis. Majority of glomeruli show presence of glassy eosinophilic intense pass positive thrombi with glomerular capillary within glomerular capillary lumen, query cryoglobulin deposits with segmental GBM double contour and segmental endocapillary hypercellularity in few glomeruli. Tubules occasional.
So
थ्रोम्बाई को एक सेकंड के लिए भूल जाओ।
हाँ, so
और
are these actual
बाकी-
thrombi?
No sir.
जो भी लिखा है, चलो इस पिंक डिपॉजिट को भूल जाओ और बाकी बताओ कि क्या है ग्लॉम्स में। How would you interpret rest of the glom or gloms?
So you said endocapillary proliferation है?
Yes sir. Endocapillary hypercellularity.
He said
Hypercellularity.
hypercellularity and
Okay.
some
So there is
splitting,
hypercellularity and
double contours.
Double contour.
double contours. So how would you label this hypercellularity and double contours? What label would you give this?
So membranoproliferative. Yeah.
Okay, so hypercellularity and double contours, you're going to label it as MPGN. Okay. So this is glomeruli. Anything else that was found in the glomerular
And you can also
space
say no chronicity because none is sclerosed. That's the other thing you could
from
say.
the glomerulus, and
From
then
the glomeruli.
and then tubular area or interstitium. What was the comments on that?
So tubules में occasional focus of tubular atrophy, interstitium occasional focus of chronic inflammation seen, blood vessels occasional arteriole at hilar pole shows cryoglobulin deposits, IF5 glomeruli, IgM3 plus, IgG plus, C1q2 plus along the GBM and within intercapillary thrombi, IgA and C3 are negative. Kappa and lambda are equivocal.
So IgM 3 plus, IgG 1 plus, IgN C3 negative,
Yes sir.
kappa lambda equal.
Equivocal. हाँ.
So what do you infer from this now?
So,
So do you want to go back to your diagnosis and rule out something? or
add
something
additional
else
ones.
came up in your mind while talking about these deposits, and then you can rule that out maybe?
Ma'am, in lupus there is full host pattern, and there is a C3 deposition is also seen.
So you say this is
IgM
not full
deposits.
house, so unlikely to be lupus.
Yes, ma'am.
You want to cross it out?
Ma'am, still there is possibility, but less likely.
Okay. And where are these deposits, by the way? IgM and IgG and C1q. What area of the glom? That also must be written.
Along the GBM, GBM
Along the capillary wall.
within. Yes,
That's
ma'am.
what Rajan was trying to teach in that meeting.
Yes, ma'am. Yes, ma'am. Along the capillary wall.
Okay. Anything else you kind of eliminate from this diagnosis?
Ma'am, it is cryoglobulinemia.
यार वो ना see
हम
again
तुम्हें उससे दूर ले जा रहे हैं, तुम उसके पास जा रहे हो.
Due to, ma'am, autoimmune pathology most likely.
so when someone says it is cryo, how does he know this is cryo? There is no way the pathologist knows this is cryo. Not on light and IF does he doesn't. There is no way he can tell you it is cryo.
उसने भी लिखा है likely cryo.
Likely
अभी
cryo
आपने
is
बोला.
different. Yeah, likely cryo
Ma'am,
is
this
different.
Autoimmune pathology, most likely some other autoimmune disease. Most
नहीं नहीं
Immune
देखो
complex
वापस
disease
अपने
है,
डायग्नोस
autoimmune
पे
disease
वो तो
भी-
सब मान रहे हैं इम्यून कॉम्प्लेक्स डिजीज
Immune
है.
complex disease है. So
तो एक तुम्हारी IgA नेफ्रोपैथी चली गई क्योंकि IgA डिपॉजिट
Deposit
नहीं
नहीं
है,
है.
ठीक है ना. दूसरा ये कापा लैम्डा बराबर है. So any myeloma related activity चली गई. So that's how you can eliminate a few things out of your list. That's what we are trying to tell you from this. Now IgM, IgG, C1q. Is there a disease where you find these three as a combo?
ma'am, rheumatoid IgM positive rheumatoid arthritis related
इसको
vasculitis.
rephrase करना पड़ेगा question. Do you think these are pathogenic here, or they just happen to be there? They are contributing to pathology, or they happen to be there?
If you had
Most
to-
like contributing to the pathology, immune complex antibodies.
if you had to prove that what is it and how is it, what would you ask for next? So
To see cryoprecipitate will take the blood.
ओके वो तो इसने पैथोलॉजिस्ट ने बिल्कुल आपको फंसा रखा है, उसने बड़ा बड़ा लिख दिया है क्रायो है क्रायो है क्रायो, ठीक है, क्रायोप्रेसिपिटेट के लिए आपने क्रायो भेज दिया. बट फोकसिंग राइट नाउ द पैथोलॉजिस्ट सेज दिस इज क्रायो, आई से प्रूव इट टू मी. हाउ विल द पैथोलॉजिस्ट प्रूव इट टू मी एंड से यस दिस इज क्रायो?
Without blood sample.
Without blood sample. What can the pathologist show me and say, here it is, this is the picture, I can tell you for sure this is cryo?
What, or I think your question, what other things look like this? Is that right?
What other things will look like this or present like this, and what can he show me? And then after that I cannot come back and say this is anything else, this is cryo. What image will he show me in 3 weeks from now?
That's a big hint.
इलेक्ट्रॉन माइक्रोस्कोपी.
उसमें कैसा
इलेक्ट्रॉन
दिखता है?
माइक्रोस्कोपी में क्या क्या ऑप्शंस हैं जो दिख सकते हैं, एंड हाउ विल क्रायो लुक? So you have classic electron microscopy deposits and look in terms of whether it is collagenofibrotic, whether it is cryo, whether it is electron dense deposits which are different. So all of those will have a different presentation. Are they aligned together? Are they in haphazard? Are they in all over the place? So that is where they will show you, and on the electron microscopy, the size and the arrangement. That is what will tell you which one is this deposit. So if you see these kind of deposits, you are not clear, you ask them, show me your EM. And on the EM, they will tell you this is the size and this is the arrangement. And that is where you now have no other choice. You can order a cryo. आपने क्रायो ऑर्डर किया, क्रायो नहीं आया, क्रायो नेगेटिव है. Does it mean that this is not cryo? So if you have you ordered a cryo?
Yes, sir.
क्रायो आया?
Yes,
कितना
आ
था?
गया?
yes, sir.
आया कि नेगेटिव आया?
सर पॉजिटिव आया था.
पॉजिटिव आया था. कितना था क्रायोक्रेट?
Positive,
खाली
negative दिया
क्वालिटेटिव
होगा ना,
खाली क्वालिटेटिव
दिया
था
होगा।
कि विद क्रिट था?
क्वालिटेटिव
क्वालिटेटिव
था।
ठीक है, ओके. सो क्रायो में व्हाट इज द प्रॉब्लम व्हेन यू सेंड अ क्रायो?
How do you send a cryo sample?
How do you
In
send
other words,
warm the solution and
Solution?
without
Which solution?
Blood है भाई।
warm the and don't and avoid use of any anticoagulant.
ठीक है.
And
So,
warm it
sample
to 37 degrees Celsius.
सैंपल लिया है, भेजा है? Anyone here who's actually sent a cryo sample?
मैंने तो बहुत साल पहले भेजा था एक।
देखा है, I've seen the vial actually जिसमें वो cryostat वो precipitate होता है ना, that I have seen.
So how was it sample collected and how was it transported?
Sir, we तो sent it directly to our lab and kept it in the fridge.
Kept it in the fridge.
सीधा ब्लड पूरा होल
Thank
ब्लड?
you.
After heating and then cooling and उसके बाद रख दिया था.
फ्रिज में ही?
नहीं नहीं ऐसा नहीं होता।
फ्रिज में तो नहीं जा रहा. फ्रिज में जा रहा है तो खत्म हो गया, वो तो वहीं
पहले
cryo
तो
हो
उसको
गया.
सीरम को सेपरेट करना पड़ेगा।
हाँ, सेंट्रीफ्यूज नहीं किया तो फिर तो
37 पे ट्रांसपोर्ट करना पड़ेगा, फिर उसका सीरम सेपरेट करना
मैम ने
पड़ेगा,
जब
फिर
किया है
फ्रिज
वो
में।
मैम ने तो बगल में रखा होगा, आर्मपिट में रख के लेके
That's a
जाते
good
थे.
idea वैसे। rather than
That was the usual way in the old
I
days.
thought एक थर्मस गर्म पानी में type
So you used to
Small cup
you
and-
could have a water bath, which is means, but the problem with the water bath is then
it
it
may
has to
be
be hot.
hotter.
How is it going to be there? So the other way was you take it in your armpit and you keep it in your armpit all the way to the lab, so that it remains
at 37 then.
So that used to be the old way, but now you should have other baths or other kits that you can
तुम
use.
लोगों ने क्या किया था? Let's hear from him.
नहीं पता होगा मैम, वो तो लैब वाला आके लेके जाता
नहीं,
है.
now that you have a cryo biopsy, you go back and read and realize there's a big deal in sample collection.
Yes.
Okay?
So find out.
मैम
Find out.
प्री वार्म ट्यूब्स आती हैं तो उसी टाइम उसका
Pre-warmed
Pre-warm
tube.
tube आ गई, but वो
तो
pre-warm
ठंडी हो
tube
जाएगी
कहाँ
2
से?
सेकंड में।
Exactly.
18 degrees inside the hospital.
उसमें उनके पास होता है वो थर्मस वो होता है. मैंने एक्चुअली आई हैव नॉट सीन दैट पेशेंट एट दैट टाइम, बट मैंने पर
कुछ था एक।
लैब से पूछो, क्रायो भेजूंगा तो कौन आएगा, कौन करता है, right? Again, so these are things that you've done it once, you've
You
seen
remember
it once,
it for a lifetime.
you will remember it for life, and you will not remember it from the book, period, full stop. You see a patient, you read with that patient, you will remember it for life. You read it separately, cover to cover, नहीं याद रहेगा. So patient देखा है, आ गया एक क्रायो तुम्हारे पल्ले, उसका ऐसा चेप लगाओ कि फिर कभी कोई
10
क्रायो
साल
पूछे
पढ़ने की जरूरत नहीं है।
कुछ, because right now is the only time you will remember. Because why do you remember? This is, I'm going a little into adult learning theory. You remember things where there are connections and layered. Right now, when you see this patient, you have the patient's room, the smell, the taste, the light, all of it is layered in your mind. You layer it with your knowledge. Everything is going to get layered together. 5 years later from now also, when you remember your cryo patient, you will remember the room in which you had seen the patient. If you can look into your history, what are the patients and stories you remember? You will remember the room, you will remember the patient, you will remember things. And you will remember everything else that you learnt with it. Because it is all layered together, you pull one memory out of it, all of it comes together. And so that is how you will remember things. Otherwise, cover to cover में सब भूल जाओगे. आज पढ़ा है कल सब गायब हो जाएगा.
Memory is about associations.
Associations and putting it together and layering it together. And you layer it together, one, by reading when you're seeing the patient, second, by teaching it. Because now when you teach it to someone or tell it to someone, you have pulled the same stories, they have now layered together, and now you teach it to someone or tell it to someone, they are layered together. So that is how you remember First learn it with the patient, then tell it to someone. Layer हो गया, अब नहीं जा रहा कहीं. So साथ साथ में एक बारी देखोगे, एक बारी टेक्नीशियन से पूछोगे, सब चिपक जाएगा. ठीक है.
So she is Hep C negative, positive,
Negative.
negative,
Okay.
antibody negative, or you have done RNA also.
RNA भी negative.
RNA also negative.
Okay. So you have a cryocrit which is positive. So let's say your cryo comes negative, but you still think this is cryo. What other tests can you do as a surrogate for cryo? Which is likely to be, it's a false positive test, but it will tell you or make you suspicious for cryo. Rheumatoid factor. So that's another way of getting surrogate to cryo is a rheumatoid factor. So that's another way. If you don't want or can't trust the lab to carry it in the right manner, you can do a rheumatoid factor. That's a surrogate way of getting to that. So now you have a cryo with a possible ANA, and you have this kidney disease. What do you want to do for her? तो पेशेंट तो आ गई.
अब इलाज. अब इलाज.
एंड पेशेंट का हस्बैंड जिससे आप बात कर रहे हो वो कह रहा है प्रोग्नोसिस क्या है, क्या होगा मेरी बीवी का, एक बच्चा हुआ 1.5 साल पहले, अब मेरे को दूसरा करना है.
First we'll try to find out the etiology.
अब कौन सा रह गया, क्या और क्या ढूंढना है? What else do you have to look for etiology?
Sir, her anti-Rho and LA was positive, Rpgn syndrome, but we'll try to confirm the diagnosis. But she did not have any feature of that disease.
Okay.
And we had we have to rule out other causes like rheumatoid arthritis, Rpgn syndrome, any lymphoproliferative disorder.
So how are you going? So rheumatoid arthritis के लिए तो ठीक है, आपने rheumatoid factor किया. I'm sure rheumatoid factor तो पॉजिटिव
आएगा ही आएगा.
वो तो पॉजिटिव आ ही गया. फिर अब क्या करोगे? तब इसको rheumatoid arthritis है.
No sir, she doesn't fit into
Rheumatoid तो नहीं है.
fit into the criteria of rheumatoid arthritis.
ठीक है, तो फिर अब क्या?
Sir, मैनेजमेंट में इम्यूनोसप्रेशन का रोल.
Okay, so what do you want to give her?
We have already given her steroids already.
So did she receive just one round, or did she also receive the one round at 2.5 creatinine outside? She got one round outside, or she got advised but didn't take it and came to you?
She received actually.
So she received one round of IV steroids at 2.5. She's now received a second round of
Yes sir.
of 503 times, second time. So she's had that
Oh, she's had 2 rounds of 503 times.
503 times.
That's quite a bit.
Yes.
ठीक है. So अब
Anything
क्या करना
else?
Sir, based on the symptoms, if she has can give rituximab, B-cell
Okay.
modifying drugs to patient, which can be first 2 doses after first doses rituximab and repeat it after 2 weeks and then every 6 weekly.
6 weekly?
6 monthly.
Okay. So अभी इसको आपने क्या दिया क्या, and how did she? So she got the 3 doses of Solomedrol. Has she had any response?
Sir, initially,
She's gone.
Creatinine?
sir, her AKI, no, she's initially, sir, her AKI improved, creatinine improved slightly, but after biopsy, she was given Ritux. She showed initial response, but after few days, her platelets dropped, and she developed severe thrombocytopenia. And evaluation for the thrombocytopenia was also done, and her PBF for schistocyte came out to be positive, and Adam TS level was also sent, which was normal. APLA was sent, which was also negative. So she was managed with plasmapheresis, and she developed TMA post 3-4 days back. So she is receiving plasmapheresis.
I don't understand this TMA now.
So
she
here,
developed post after 3-4 days. She developed TMA.
no. Is there a logical explanation that you have? You have
No,
any? I can't think of TMA in this disorder now.
but patient developed TMA. That is.
So when
No,
you're
no,
saying,
I
so,
agree if you're-
so you're saying TMA based on that her platelets dropped,
And
and on your
how many
peripheral smear,
schistocytes?
peripheral smear you
8%.
saw schistose. What was her hemoglobin drop, and did you have to transfuse her again?
So yes, she received 2-3 transfusion. She received 2 more transfusions, blood PCV transfusions.
So before the biopsy or after the
After
biopsy?
the biopsy.
After the biopsy,
Before biopsy, she received only
1 unit.
1 unit. After then, she improved slightly, and we were planning to discharge her, but her platelets dropped, and suddenly dropped. Though she didn't have any bleeding, but her platelets continuing to drop, and her schistocyte was 8%.
8%.
8%. First,
So this could this be
And this is after
microthrombi of
Ritux.
cryo
this is
causing?
after Ritux.
sir, after Ritux, but I don't think it is related to rituximab. Rituximab is very unlikely to cause TMA.
Your
And do you
unit
get-
has any
do you have-
explanation for
do you-
this?
Do you have a reason why she required transfusions when she had her pregnancy 1.5 years ago? And what time frame did she need the transfusions?
She received in late 2nd and 3rd trimester.
Before delivery, after delivery? Before delivery.
Before delivery. She was anemic. I asked her, but she don't have khoon kam tha. She didn't.
नहीं, see again.
Nobody
So,
She
receives.
did, during
Yes.
pregnancy, her
Yeah, कुछ
pregnancy
पहले से
was-
चल रहा होगा इसमें.
so again, so the other question would be, does she have some kind of a complement deficiency,
Yes, sir, a
and she is
complement.
getting a second hit?
Yes,
And
sir.
so this second hit can be from
Yes, sir.
cryo this time, and previously was from her previous pregnancy.
To give
So-
someone 2 rare diseases is a bit too much.
Yes.
Is a bit
So-
too much.
Yes. So
First of all, a complement related disorder and then cryo.
yeah.
There's
So
something
means
amiss
again-
here. There's something amiss here. I
So-
don't get it.
Yes, ma'am. And complement studies were also signed up. And reports are waited. This is 2 or 3 days.
Yeah. So again, genetic complement mutations can
Are-
be there in people, and they have not had any issues before till means, which is something which we know in
Second
pregnancy or second hit that happens, and so that hit happens. In her case, it could be whatever autoimmune disease is the second hit, and that is triggering her complement mediated event as well. So that could be, and could be that was there before as well. But yeah, this is
This is beyond
EM.
me at
So
least.
one, I would definitely want EM to see what is actually on the EM in the deposits. Are they IgM? Are they cryo? What is it that is in the deposit? So that would be definitely something that would be good to see. इसका वो भी किया था इलेक्ट्रोफोरेसिस, सीरम इलेक्ट्रोफोरेसिस या वैसा कुछ?
Kappa lambda यहाँ पे सब बराबर है. That's the only thing.
मैं अलग, मैं IgM and मैं
Waldenstrom types.
Waldenstrom, मतलब again 33 में.
So the other
again,
thing
that
he
would
said,
Initially it was
yeah,
not-
the other thing he said was these are intracapillary thrombi types. So those happen more with those malignancy related things.
नहीं, no, she was not evaluated. At that time, she was not evaluated for any blood.
No, that's
When
also
we-
many disorders, na?
Yes.
Multiple myeloma,
Myeloma,
Waldenstrom,
means again
CLL
you would-
also,
Yeah,
which
means you would look
unusually
for
could be-
Waldenstrom means again cryo with Waldenstrom is well described, so
Yeah,
that would
that
be
is
another.
exactly.
So that
So-
would be another kind
So
of.
I believe
pathway.
it forms thrombi, especially when it's those disorder associated rather than immune complex. Which scan? No lymph nodes anywhere. So that rules out a B cell lymphoma or whatever. Chalo, rare disease, do more.
कुछ तो अभी
कुछ
तो
ना कुछ
I would-
explanation हो. There's something missing somewhere. That's what I would imagine. Your unit has any explanation which you can tell us? नहीं.
इसीलिए तो यहाँ है।
सडनली हो गया था पहले तो एक्सप्लेन ही था सडनली प्लेटलेट्स ड्रॉप हो गए 2-3
नहीं नहीं वो ठीक है. देखो प्लेटलेट तो शुरू से लो है. 80,000 also is low. It just fell further. So we were
And
running
ये
on
सडन
a-
ही होते हैं प्लेटलेट कभी भी धीरे 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 धीरे
नहीं,
करके नहीं
दूसरा
गिरते
ये
गिरते
होता
तो
है कि-
गिरते हैं
ठीक आई थी
हाँ,
एक
गिरते
वहाँ
कई
से
बार
कम थी,
एंटीबायोटिक
जहाँ
इंड्यूस्ड ये ड्रग इंड्यूस्ड ये सब बीच में ऐड हो गया होगा कुछ.
मैम उसके
बट
बाद
देन
normal भी हो गए
TMN
थे
होना
platelet.
जरा मुश्किल है.
प्लेटलेट नॉर्मल भी आ गए थे बाद में इनिशियली फर्स्ट रिपोर्ट जब थ्रोम्बोसाइटोपेनिया था बाद में नॉर्मल भी हो गए थे प्लेटलेट्स
बोन मैरो कोई नहीं हुआ.
नहीं अभी नहीं किया अभी प्लान था फॉलो नहीं किया था मैंने
That will test
Plan
at
for
least
bone
the
marrow.
factory is okay.
कुछ तो to get to
So did you
antibody was positive.
yeah
बट ही
which one?
anti-ro
Sjogren
But
is a
Sjogren's
common
में
association
TMA
with cryo,
TMA
but TMA doesn't fit in. That's our problem right now. TMA doesn't fit into cryo. Did you Google cryo and TMA somewhere?
cryo
Yeah, that doesn't kind of click anywhere. Sjogren ठीक है चलो. Huh?
Vessels can be involved in Sjogren's.
but he didn't have any feature of
usual in Sjogren's would be you get interstitial nephritis, you get electrolyte abnormalities, so that is you get calcifications, so those are RTAs, so that is the usual Sjogren kind of, if you say Sjogren in kidney, GNs are
And that
lower,
is relatively uncommon.
GNs and GN like presentations are unusual in Sjogren's, majority
But-
will be this
yeah.
kind of presentation.
Usual is interstitial nephritis and RTA.
and RTA.
Cryo is
And then
there.
you'll have calcifications and nephrocalcinosis and those kind of things. So that's the usual kind of Sjogren presentation. So, so that's kind of, so cryo हो सकता है, that's fine.
Cryo
Autoimmune
तक हो
diseases
सकता है,
हैं,
लेकिन
autoimmune
TMA
mixed
कभी
benefits,
सुना
but
नहीं.
Yeah, TMA would be hard pressed to kind of
Correct.
come up with,
अब LDH कितना है? You did an LDH earlier.
which was normal.
Yeah. Have you repeated it? No.
Initially it was 1,900 when this episode was occurred.
इस
Which one?
1900,
To begin
1900
with.
LDH. No, not to begin with. When this.
when this
जब
started,
TMA चल रहा था तब
जब ये
1900
TMA आ गया.
पहले
So
normal
that
था.
all fits in.
initially
दूसरा
Schistocyte was also
फेरिटिन
normal.
कितना था? अब मैं आपको एक और
HLH.
yes
क्या चीज
HLH
Ferritin पूछोगे तो HLH ही है.
yes. So again now we are going into so autoimmune diseases with HLH. So
हो
that
सकता
would
है.
be a much more likely in my
उसमें हो
mind.
सकता है.
Autoimmune disease with HLH would be a much more likely diagnosis than or primary HLH means we are now talking this is likely autoimmune disease related.
Yeah,
but that
primary I
would be-
believe
primary
manifests
तो
in
autoimmune हाँ वो
छोटा
autoimmune-
बच्चा
छोटा बच्चे में होना
छोटा
चाहिए. But
बच्चा में
yes,
होता है
autoimmune
primary
disease
तो.
with HLH ferritin
It was 8% surgery.
That he told us 8%. No, HLH can have TMA and HLH can accompany 1,000
lots
disorders.
of other things as well.
Yeah.
So that would be another.
Any
So
autoimmune disease.
triglycerides and ferritin would be another thing to look at.
That could explain it, yeah. And bone marrow, again.
Yes.
It takes you back to
Back
bone
to
marrow
bone.
then.
Bone marrow
That
में दिख जाएगा.
diagnosis comes from
Well,
bone marrow.
पेरिफेरल स्मेयर में दिख गया एक अकेला कहीं पे खाता हुआ तो फिर तो खत्म
वो
हो
तो
गया, बट मुश्किल है।
वो इतना कौन
Bone marrow में
देखेगा?
दिखेगा।
बोन मैरो तो HLH के लिए जाएगा तो
Yes.
देख लेंगे.
HLH
That could explain it actually.
वैल्यूज रिमेंबर नहीं है बट HLH के क्राइटेरिया
Ferritin नहीं
फुलफिल
था।
नहीं हो रहा था. HLH के लिए
10,000 चाहिए उसके लिए तो ट्राइग्लिसराइड भी हाई चाहिए. बट बोन मैरो करा के देख लो. आई
बोन
थिंक
मैरो उसका होना प्लान किया था पहले बट
And ferritin may be many times they will say more than X and not dilute. So you will usually have to then ask them to dilute it and tell you whether it's in the many times the cutoff is 2000.
yeah, that's one possibility.
So वो है, so that's another one कि कुछ unusual बनाने के लिए. Yeah, सीधे सीधे तो नहीं बन रहा.
CPC के लायक हो गया है ये तो. ये तो CPC के लायक हो गया.
One possibility would be complement disorders as baseline, autoimmune triggers a TMA. That would be one. You have a complement deficiency. Another would be you have autoimmune and then you've triggered
I
a
think
severe.
two rare disorders somewhere.
Yeah,
I don't
कुछ
know.
तो.
It's चलो. But HLH के लिए तो देख ही लो. That's something which happens here. It does. We just don't pick it up. It does. Chalo, with this twist, the case became interesting. That's what we can say. Anything
Can't
else
come up with-
we can kind of
Questions, concerns, or whatever,
concern,
or things
questions,
you want
comments.
to ask related to RPGNs or GNs
Anything.
and evaluation of or thought process. Again, an individual case, getting to the diagnosis, no one in the exam is going to be looking or asking for you to tell them the perfect final diagnosis. What they're looking for is how do you approach a case or a history or an exam and how do you present them. And so I think that is what everyone in the exam is looking for. No one's looking for the right answer. So even if you get the answer, the actual answer wrong, but if your approach is right, they will give you good marks for it. And if you do the reverse, your approach is wrong, but you got the answer, they're going to ding you for it. Because they will say someone told him the answer, which is why every time we ask him, even though the presentation is not what he is describing, he is stuck to that answer. So, which is why you can, even if you know the answer, forget about the answer. Forget about the diagnosis. Go approach as if you have no idea about it. And keep your options open. Whenever you make a differential, keep it all broad and do it systematically. So, every time, this is something I will say is, whenever you see a patient in the OPD or in your IPD, write your differential on there. And then when your consultant comes to see it, ask them, is there something else that I am missing in your differential? And how would you approach it as I approach that patient? If you do it every day in your year, in the year, you would have done 300, 400 of them. Even if you do just one patient every day and you make your differential when you present it, every day, you've done 300 of them by the time the year is done. So just at least one patient a day, do it, write it. Verbal karoge, andar karoge, write it on a piece of paper and have your consultant review it. You can write it in the note, in the chart. Because once you've written it, you can't go back on it. You have your thought process, you've analyzed it, you've put it. Now, when the consultant says, no, I would add this here, I would add that here, it will get stuck in you. And then the next time around, you will add those in your list.
And one urine a year.
A year. A year. So that is
So
3
then
years.
they would have
So
done
3 years,
three.
3.
Three at least.
ठीक है.
कुछ तो कर लेंगे.
नहीं.
No, if
आसान
you
है.
follow this method, you'll be great.
आसान
But
है. I think.
आसान नहीं
I
है.
think,
I suppose इतनी perseverance आसान नहीं है, but
yeah, नहीं, I
कुछ तो कहीं ना कहीं कर लो. It helps. चलो, good अपराजित.